going on, everybody? Welcome back to another episode of the Core Consult RX podcast. My partner in crime, Cole. How's it going, man?
Good, man. Feels like it's been a while, but it's just because I went on a couple vacations, so we recorded kind of ahead of time. So good to be back.
We were ahead of recording instead of the night before.
Doesn't happen too often, except for vacation and holidays maybe.
Yeah. Not too often are we ahead, but definitely does feel like it's been a minute. We've definitely been trying to be consistent with episodes. At least the accredited ones are pretty consistent. But we've with this whole 2-kid business, I feel like it's definitely slowed us down a little bit.
Yeah, it turns out that takes some time.
It sure does. But so tonight's accredited episode, Cole, you want to tell everybody what we're talking about?
Yeah, so we're talking about Crohn's disease, which we haven't talked about in a long time. So there you go.
At least we think.
We're pretty sure. It felt very familiar.
We did a relatively strong search through our episodes.
It felt familiar, but we were pretty sure it's because we did ulcerative colitis recently. Or not, I mean, exactly. in the not too distant past. So hopefully that's true.
Hopefully that's why it seems familiar. Yeah. But if not, well, you'll get it again.
Somebody tell us.
But before we jump into it, do you want to talk about your plugin that you created? Because I want to hear how it's going anyway.
Yeah, going fine. Just quickly, MedSearch Chrome extension. It's an extension for the Google Chrome browser. Can help you pull up medical information more quickly, save a few minutes in your day. If you go to the Google Chrome store and search MedSearch, or if you just search MedSearch Chrome extension on Google, it'll come up. But yeah. It's going fine. And
you can sort of customize it too, right? Based on like what subscriptions you have to like up to date or whatever it may be.
Yes, you can. It's preloaded with I think like 13 popular search engines, medical search engines, but you can customize it with whatever you prefer. That's correct.
That's cool.
Yeah,
that's awesome.
Yeah.
Have you gotten any feedback or anything from anybody using it so far?
Nothing negative, so that's good.
Well, that's good. Yeah. It's better than our podcast comments, but no, that's awesome, man. I'm glad it's going well.
Thanks. Appreciate it.
So, like he said, Crohn's disease tonight, and it is an accredited episode. So make sure, for those of you who are free CE members, after the episode, use the password that we'll give you at some point during the episode to go to Free CE's website. And when you click on, I haven't looked at their website in a little bit, but now when you go to like your home study options, you click on the filter, it'll say like content type or something like that, and then podcast is listed on there. So that's how you can find our like a list of our episodes pretty quickly. But go to this episode, use the password to activate the post-activity test, and past that, you'll get your 1 hour of continuing education credit for pharmacists and nurses. And again, thanks as always to freece.com. I think too, I got an email from somebody that was saying that they were a pharmacy tech and they like our podcast. Maybe we need to talk to them about including pharmacy techs, even though not all of it applies to them necessarily.
Yeah,
we may need to figure that out so we can get our tech brethren, along for the ride.
Yeah, I'd love that. I certainly think there's enough that applies to where it could count for.
Yeah, I think so.
There was
sure.
I can't recall why it wasn't originally targeted towards technicians. Maybe it's because it's more therapeutic approaches and things, and so I don't know. But yeah, I think that'd be great.
I'm sure. I mean, yeah. If nothing else, just the drug info stuff that we go over, I feel like would be very applicable. So
yeah, agreed.
Yeah, we'll have to talk to them. So for the listener who reached out, because I can't remember if I emailed them back yet, which it's on my to-do list, but know that we'll work on it for you.
I did, so don't worry.
Did you? Oh, you're the man.
I think I CC'd you, so hopefully you'll see that.
Did you? That shows how well I check my email.
Yeah, that was actually a quick. It was a quick reply. I don't know. I saw it and I think I was working on the stuff for an episode, so I just replied and I was like, look at that. Awesome. We replied quickly to something.
That's incredible. Good for you. Thanks, man. I'm glad you did that. Yeah. I'll check that off my to-do list then. That's awesome. So Crohn's disease, as we've talked about before, like also we recently or somewhat recently did ulcerative colitis, and so kind of the umbrella term that you'll see is inflammatory bowel disease, IBD, and so that kind of encompasses both Crohn's disease as well as ulcerative colitis, but they are two very different disease states, and the management of those disease states is very different as well. So IBD is referring to diseases of chronic or at least this relapsing, remitting intestinal inflammation situation where patients are presenting with things like diarrhea, abdominal pain, and various other symptoms that we'll discuss. But ulcerative colitis is more the mucosal inflammatory condition that's confined to the rectum and the colon, whereas Crohn's disease is transmural inflammation of the entire GI tract, and it can affect any point from the mouth to the anus. And so it's potentially a lot more area that we need to target potentially.
Right.
And so it definitely, even though they are kind of both under that inflammatory bowel disease umbrella, they're very different disease states to manage.
Right. There are some differences. Similarities are that IBD, both of these disorders have a complex etiology. They involve the immune system, their autoimmune responses, specifically inappropriate T cell responses to intestinal flora, overproduction of tumor necrosis factor, overexpression of interferons. Also, there is the risk for infections, loss of tolerance to or altered normal flora. So you can get bacterial overgrowth, and the bacteria can be toxin producing. And both of them have a genetic component as far as the risk factor. There is a high twin concordance rate, and several genetic biomarkers have been established for each of them.
And there's also some environmental complexities that kind of fit into that etiology as well. So, for example, the Western diet seems to be a higher risk factor for developing IBD in general. Just tend to have low in fiber, high in sugar, a lot of additives, refined foods, things like that. And so that overall Western diet seems to be a higher risk factor. Nicotine is kind of a weird one though, because nicotine tends to worsen Crohn's disease, whereas it's actually somewhat protective of ulcerative colitis. Not to say that obviously that we want people to smoke or anything if they have ulcerative colitis, but it's just one of those things. If they are smoking and then stop, it could cause a flare up. But nicotine, from Crohn's disease standpoint, tends to make things worse. There's also medications that can cause some flare ups or trigger a flare up. The NSAIDs would be a very common medication class that would be notorious for causing issues with the GI tract in general. And then, any type of medication that could potentially cause diarrhea as a side effect. If possible, we would want to try to avoid those. Now, obviously, there's some instances like with antibiotics where we may not be able to, but again, if we have to go that route for whatever reason, then just kind of warning the patient to be on the lookout for a potential flare up. There's also a lot of psychological, factors that we have to consider when it comes to patients that are living with IBD. The mental health changes have been loosely associated with the rate of remission and flares. And so you have a patient who's highly stressed, dealing with a lot of anxiety, maybe going through a bout of depression. And this tends to be more coinciding with ulcerative colitis, but it can happen in Crohn's as well. And so when patients are going through some of these mental health struggles, that tends to increase the risk of a potential flare-up of their disease, even if it is in remission at baseline.
Right. So that's a lot of things that come along with both of them. As far as some differences, there's some differences in clinical features. There's also some differences in pathologic features. As far as clinical features, really the only common one between them, as far as main features go, would be rectal bleeding. Crohn's disease can also have malaise and fever, whereas ulcerative colitis usually doesn't. You're probably going to have abdominal tenderness, maybe even an abdominal mass or abdominal pain with Crohn's disease. These are more unusual or even completely absent with ulcerative colitis. The distribution of Crohn's disease is discontinuous, whereas you get a continuous distribution with UC. As far as pathologic features, rectal involvement is rare in Crohn's disease, but common in UC. Other factors that UC does not have, but Crohn's disease will probably have, is ileal involvement. Strictures are more common in Crohn's. Fistulas, transmural involvement. Though crypt abscesses, that's going to be rare with Crohn's, but it's going to be a kind of defining feature of UC that I think we've already mentioned. Granulomas, linear clefts, cobblestone appearance, that's all more indicative of Crohn's, less so of UC.
Yeah, absolutely. And, I think from a test question standpoint or boards question, if, for some of the more basic questions that may be on there, I think those things that we talk about, like in Crohn's, like the transmural inflammatory situation is always should point you in the direction of Crohn's. And then when you talk about like those discontinuous lesions or skip lesions they're referred to, and then cobblestone appearance, that should be like an immediate, like on your radar for Crohn's. For those of you who are doing multiple choice type tests or board exams or something. And then crypt abscess, I feel like it's the same kind of thing for like ulcerative colitis. That should definitely send off the radar. Clinical presentation. Patients oftentimes will have chronic diarrhea, although not grossly bloody, typically. Patients are often experiencing abdominal pain with right lower quadrant tenderness, and that tenderness may actually be partially relieved by defecation. There's also situations where patients will, sort of present with fever, as well as weight loss, because, they're just not able to absorb nutrients as well. And then that can eventually lead to, overall like malabsorption. And so obviously can really, cause a lot of strain on someone's quality of life.
Yeah. And I think that's what most people think of when they think of Crohn's is, just stomach issues, having to use the bathroom and maybe having to miss out on certain things because of that, whether it's school or work or whatever. There are definitely some serious complications that can arise. I mentioned fistulas. So that's a formation between the colon and another part of the intestine or bladder and can cause problems. You can have a small bowel obstruction. Mike mentioned malabsorption, so specifically B12 deficiency is something that can happen. Interestingly, increased risk for nephrolithiasis because increased absorption of oxalate from the diet can lead to calcium oxalate stone formations, and that can be associated with Crohn's. Also, an increased risk of malignancy, though UC has a higher risk. Compared to Crohn's, there's still increased rates in individuals with Crohn's disease.
And then as far as like staging the severity of someone's Crohn's disease, once they've actually had the diagnosis, unfortunately, there's not like a global classification system. The majority of clinical trials, historically anyway, have utilized the Crohn's disease activity index to basically assess the therapeutic outcomes in those studies. And so an individual may be in histologic remission, endoscopic remission, clinical remission, or surgical remission. And so score-wise, an individual is in symptomatic remission, usually corresponding with the activity index score less than 150. When that patient is asymptomatic or, basically without any symptoms of inflammatory sequelae. Individuals with mild to moderate disease, usually corresponding to a score of 150 to 220, those patients are able to ambulate and able to tolerate oral elimination without manifestations of some of those more serious risks, dehydration, systemic toxicity, where the fever might come from and whatnot, abdominal tenderness, painful mass, intestinal obstruction, or if they typically haven't had a greater than 10% weight loss from their symptoms.
Right.
Then, when you get to the moderate to severe disease, from a score standpoint, you're talking 220 up to 450. Those patients are considered to have failed to respond to treatment for mild to moderate disease, as well as that, obviously, that scoring system. And then those with more prominent symptoms. So they may have like the systemic issues like fever, significant weight loss, the abdominal pain and tenderness. They may even experience intermittent nausea and vomiting, and that's going to happen without obstructive findings as well. And then also those patients may even become, anemic. And then if you have severe, or the most severe situation being fulminant disease, those patients have a activity index score of greater than 450, and they're going to have very persistent symptoms despite the introduction to conventional corticosteroids and other biologic agents, even in the outpatient setting, and very high fever, persistent vomiting, evidence of intestinal obstruction. Obviously very complex and severe symptoms, and those patients will oftentimes at least be started off on therapy inpatient to kind of get their inflammatory response under control.
Okay. Anything else before we talk about some treatment options?
No, I don't think so. Just jump into mild Crohn's and we'll kind of work our way from there.
Yeah, kind of work our way similar fashion to how Mike described the classification. So mild Crohn's disease, you can be thinking corticosteroids for one. They are going to act by modulating the immune system and inhibiting the production of cytokines and other inflammatory mediators, just as they would in any other disease state. They're going to interrupt cytokine release, decrease leukotriene, prostaglandin, and superoxide production. So you'll see those used a lot. As we go through the rest of the treatment options and talk about induction and maintenance, the goal ultimately is to decrease the patient's steroid burden with other medications or lifestyle therapies, while also mitigating their symptoms as best as possible, because we know that, and we'll touch on it, that there's a lot of long-term issues with corticosteroids. So budesonide, for instance, branded as Entocort EC, is a 3 milligram extended release capsule specifically for Crohn's disease. It releases in the ileum and the ascending colon, which would be why it's for Crohn's disease. Its dose is 9 milligrams once a day for 8 weeks. That's induction dosing. For maintenance dosing, it would be 6 milligrams once a day for 3 months with the goal to taper off. Prednisone, starting with 40 milligrams per day, can be used for patients with mild Crohn's disease in the colon diffusely or in the distal colon as well.
And as Cole mentioned, the adverse effect profile for corticosteroids is all over the place. We typically think when we're talking systemic corticosteroids, we're thinking increased weight gain and also increased appetite overall. They can lead to emotional instability. They can cause patients to have sleep disturbances, insomnia, because they almost have like a stimulant-like effect for a lot of people. They can cause some GI upset, which is the last thing someone with Crohn's disease wants to deal with.
Right.
And then long-term, the reason why we ideally would not want to have someone on these systemic steroids, indefinitely would be, you can eventually cause adrenal suppression. They can also cause immunosuppression, impaired wound healing, depending on the dose that the patient may be on. It can affect blood pressure. Patients that at baseline that had good blood pressure may end up developing hypertension. They can cause hyperglycemia. They increase the risk of developing osteoporosis. They also will greatly increase sodium retention, causing edema in a lot of patients, and definitely a whole host of adverse effects that nobody wants to have to deal with on a long-term basis. And the one good thing about the budesonide, like Cole was talking about, is it is intended to not have as much of the systemic absorption as like a standard prednisone would. That being said, it's definitely still possibility to experience some of those side effects, and we still want to limit like he mentioned, the time frame is usually 3 months and then tapering off for the maintenance phase. We're trying not to have these patients on these indefinitely.
Right. So there are some other options with more mixed data that have been used on and off for Crohn's. Sulfasalazine, mesalamine is one example. It's not great because it hasn't been shown to consistently demonstrate efficacy for induction of remission and achieving mucosal healing in patients with active Crohn's disease. And so it's not really recommended to be used by the guidelines. It's one meta-analysis that kind of demonstrates this from 2011. Neither low-dose or high-dose mesalamine was superior to placebo at inducing remission. So you may see this done, but not recommended. There's also antibiotics, metronidazole and ciprofloxacin, but they haven't been shown to be more effective than placebo. And if the Crohn's disease affects an extensive portion of the small bowel, consider moderate to severe induction options. So we're specifically talking about mild Crohn's at the moment, and we're about to highlight more of the moderate to severe options.
Yeah, and I think the mesalamine can get confusing too, because there are some mesalamine formulations that are specifically indicated for Crohn's, but like you said, Cole, those are definitely not recommended, especially compared to some of our other newer medications that we'll get into when we talk about moderate and severe.
Right.
But with ulcerative colitis, they are still very much in use.
Right.
And so I think that gets very confusing for people. But ideally, the using another option would be a better route to go.
Right.
So looking at a case of mild Crohn's disease, one of the first things we can kind of note would be, is the disease limited to the ileum and or the proximal colon? If yes, then the budesonide that is indicated for Crohn's would be ideal. And again, like Cole said, not more than 8 weeks as far as the induction phase. And as long as the patient is responding, then you do that taper over that 3-month period to kind of wean them off of it. And then when the budesonide is actually tapered, you assess, do the symptoms then start to flare up again? If they do, then you may end up having to restart the budesonide again. And you could also consider like a azathioprine or something like that we'll get to in a little bit. But you could potentially restart the steroid at that point, assuming that the side effects haven't become too burdensome. If not, then you would just kind of monitor the patient and look for a relapse, and then ideally do like a colonoscopy in 6 to 12 months. Now, if it is not limited to the ileum or the proximal colon, then because it's a little bit more of an extensive along the GI tract, you would want to look at whether the disease involves either the colon diffusely or the distal colon. If yes, then we would want to go with systemic corticosteroid like prednisone, like for example, 40 milligrams per day for 1 week, and then you could assess if the patient's had a response to that, and if so, then taper prednisone by 5 to 10 milligrams per week over 1 to 2 months, and then discontinue. Again, the budesonide is a longer taper and all that, but you're also not getting the systemic side effects, or at least to the same extent that the prednisone would be causing. If the patient didn't respond, then you would probably want to escalate the patient's management to more of a moderate to severe Crohn's disease. Because like we mentioned, besides the severity index score, the patient not responding to mild treatment would kind of push them up into the next bracket of severity. Also, if the patient, when you're looking at whether the disease is affecting the colon diffusely or the distal colon, if not diffuse or extensive small bowel disease, then again you would kind of escalate more to the moderate to severe Crohn's disease management that we'll talk about in just a little bit. Right. And then if the prednisone works, then again monitor potential colonoscopy 6 to 12 months. If it does cause a flare-up when the prednisone is tapered off and discontinued, then you may have to restart the prednisone process over again and taper over another 2 months. But hopefully if the patient truly has a mild case, then they can remain in remission for a while and keep from having that flare-up right after treatment stops.
Right. So that's mild. And you touched on some moderate to severe pieces, so we'll move on to moderate to severe. As far as corticosteroids go and mesalamine, sulfasalazine, kind of similar recommendations to mild as far as the guidelines go. Most of the guidelines we recommend or we're referencing are the American Gastroenterological Association guidelines from 2021. For induction, they do suggest the use of corticosteroids for induction of remission over no treatment. For remission, they recommend against the use of corticosteroids over no treatment for the maintenance of remission. Similarly with mild, in terms of the 5-amino salicylates like mesalamine or sulfasalazine, they suggest not using those in induction or remission in Crohn's disease.
Yeah, and just to be clear too, when a guideline is saying they recommend against something, it's not necessarily saying that it's going to cause harm if you do it,
right.
But because of the lack of data, they can't then make a suggestion or make a recommendation for that, because the versus placebo data was not, high enough quality to merit that recommendation. And then when they say suggest use, usually most guidelines, they're kind of that's sort of a lower quality of evidence backing that, versus when they say recommended. And so that's some other just kind of verbiage there that make it a little bit confusing. But so induction, we're good with steroids compared to no treatment. But remission, they would rather you just stop the steroid altogether and just, basically monitor the patient instead of continuing that taper process, just because the data hasn't supported the long-term use for remission. But the good news is we have some other medications that we can keep in our back pocket for, the moderate to severe situations. So methotrexate, medication that I'm sure all of us are familiar with to some extent. It's a direct anti-inflammatory that it shows its benefits due to its effects on T-cell gene expression. And for Crohn's, typically you'll see an initial dose of 15 milligrams up to 25 milligrams once weekly, given as an IM or sub-Q injection. Methotrexate can be used continuously for years and years, and there's even some studies that have kind of showed that safety profile and sustained benefits can be maintained for decades. So it's a drug that's been out for a very long time. It is considered contraindicated for a patient who's pregnant, and the recommendations are that men continue an effective form of birth control for 3 months even when they come off of the methotrexate, because basically one cycle of spermatogenesis is 74 days. And then a female patient who's on this, that they should be on an effective birth control for at least one ovulatory cycle when they come off before, attempting to conceive. There's also some drug interactions to be aware of. So they can serum albumin binding interactions with salicylates, phenytoin, sulfonamides, trimethoprim, ciprofloxacin, even thiazide diuretics can potentially cause an increase in methotrexate toxicity. And so that's just something to kind of be aware of and watch out for, depending on the patient's comorbidities. But methotrexate's been around for a long time, and the good news is we have that long-term, safety and efficacy data that, supports its use if we go that route.
And it's used on a lot of other conditions, specifically rheumatologic conditions. You see it used all the time. As far as we mentioned the injectable formulation, so it does come in an oral formulation, used a lot in the rheumatology realm, but kind of makes sense that the guidelines suggest trying to use the injectable formulations, either the sub-Q or the IM form for Crohn's disease, and they suggest against the oral methotrexate for the purposes of, I would imagine, GI upset, I suppose, or potential decrease in efficacy related to the condition. But they suggest,
I think Crohn's disease specifically, the efficacy isn't as strong with the oral. So again, going back to that verbiage, they suggest against it, not that it's going to necessarily cause harm, but also the lack of efficacy. They can't then in good conscience say they recommend or suggest it.
Right.
So IM or sub-Q methotrexate, definitely, but not the oral formulation.
Yep.
So thiopurines, another group of medications that have been around for quite some time. These are immunosuppressive agents. I would say, at least in my experience, the more common agent in this class that you see people on is azathioprine, Imuron. And the other option is mercaptopurine. You see that every once in a while, but at least, like I said, in my experience, I feel like azathioprine is used a lot more commonly. Azathioprine does carry a box warning for the risk of chronic immunosuppression. And the other risk that goes along with that box warning is an increased risk of malignancy. And it's seen specifically in patients with IBD that are using this. Now, outside of the box warning, there's still some pretty severe warnings that we should be aware of. It can cause hematological toxicities potentially. And then there is the risk where patients may have a genetic deficiency of thiopurine methyltransferase, and that you'll see it abbreviated as TPMT. Ideally, you would want to have the patient undergo testing for that and assess to make sure they don't have that deficiency, because if they did, obviously the medication is not going to be as effective. And that also applies to mercaptopurine as well. But that would ideally be done before initial use of the thiopurines. And then we talk about just kind of more common side effects. The GI issues, nausea, vomiting, diarrhea have all been reported, rash, and then also a potential increase in LFTs. And then, mercaptopurine is very similar to azathioprine, although it doesn't have the same box warning. And it is recommended for absorption reasons that mercaptopurine be taken on an empty stomach. So kind of a quick clinical pearl for that one. But the good thing is both of these have been used in the long-term treatment of both Crohn's disease and ulcerative colitis. You'll see it used in both disease states. And, that long-term data is definitely a good thing to have to support the use. But that data is available for both agents.
Right. In terms of the guidelines, these are going to be more remission medications. So the guidelines suggest against the use of these in induction over no treatment, but they do recommend them, or they suggest the use of them in remission. So if a patient's in remission on their own, meaning they don't have any symptoms post having an induction period or just going through a period of remission, they suggest it. But also if a patient has corticosteroid-induced remission, they suggest using these, presumably to reduce the steroid burden in those patients.
Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show. Yeah. And for those of you who are worried about like all these suggest against and suggest for and all that, at the end we'll definitely summarize all this again. So don't feel like we're just flying through this stuff as far as the actual guideline recommendations go.
We always give a nice summary at the end, right?
The best. We're actually known for our incredible
You could just skip
summaries.
to the end and listen to the summary, then you don't have to listen to the whole thing.
That's actually very good.
But then you would miss the
call.
password, which this is probably a good time for that.
It's got to be an AI program that'll tell them what the password is. We'll just scan our episode.
That's true. Probably so.
But you wouldn't want to do that because y'all are very astute learners.
You're all studious people. Yes.
Yeah.
Studious, honest people.
Yeah, exactly. Do you want to do the password real quick?
Yeah, go ahead.
So the password for this episode will be Crohn's 24. So CROHNS 24, and the letters are all capitalized. And so that will give you your, and again, that's on FreeCE's website underneath their list of episodes that we have on there that are accredited. Click on this one specifically, and then use that password to take your 10-question multiple choice quiz, get your 1 hour of continuing education credit. Pharmacists and nurses, and hopefully soon pharmacy techs.
Yes. No apostrophe in Crohn's, just the
correct
the letters and numbers.
Yeah. We don't care about punctuation when it comes to passwords.
We don't care about those high commas.
Not even a little bit.
No. Okay. So next class of medications are TNF alpha inhibitors. We see these used in a variety of disease states as well. I won't tell my story about the professor I had who the answer to all his test questions was TNF alpha related, because I've told that story multiple times.
He's the one that like worked on those, right, when they first came out?
Yes, he was like researching or something. But they're all over the place now, and they induce pro-inflammatory cytokines, interleukins. They enhance leukocyte migration, activate neutrophils and eosinophils, induce acute phase reactants, tissue-degrading enzymes, and they are the first-line biologic therapy for Crohn's disease.
And there are a few different options under the class of TNF alpha antagonists. So we have a IV infusion formulation, infliximab or Remicade, and it has been historically only available as IV. Although I was reading through some of like the news from the one big GI conference that they have. I can't remember if it's nationally or internationally, but just reading some of the studies, and apparently they are working. To my knowledge, I don't believe it's, don't hold me to this, but I don't believe it's approved yet. But they're working on a sub-Q formulation, and it looks like it's just as effective, and can be, even if you're on the IV infusion, you can switch over to the sub-Q. So it looks like that's coming. I may be late to the party, and that may be already approved, and I just haven't seen it. But
I thought
pretty
I heard
sure.
about that. Nice.
So
like
if nothing else, it's definitely coming. Yeah.
Yeah.
And then a very commonly seen TNF alpha antagonist is adalimumab, Humira, which is also a sub-Q injection. And then one that, at least in my experience, I don't see as often is citralizumab pegol, which is the Cymtiza. That's also a sub-Q injection. And there are also multiple biosimilars that are available now, especially for Humira. I feel like there's so many.
They're all over the place. And now, like as of this new cycle this year, all the insurances are just making everybody switch. So
I'm sure
for people who have been on it for a long time, or for just people who are dealing with it, it's a lot to manage just with all the different biosimilars and all that.
Yeah. There's definitely a lot going on, but hopefully, the purpose, I think, is to drive down cost, which I don't know how effective that's been so far. I haven't, looked too deeply into
Certainly
that.
Some of them are cheaper.
Maybe a little bit.
Certainly some of them are cheaper. Some of them are not that much cheaper. It's incredible the variation in pricing. I'm sure the contracts and all that determine that, but as far as what I've seen, we're able to get versus not get, there's a large variety of prices.
Yeah, for sure. These TNF alpha antagonists do carry a box warning, and because of the fact that they increase the risk of serious infections, and some infections that have been thought to be caused from the patient being on a TNF alpha antagonist have actually been fatal. And these infections aren't just bacterial, but they can also be TB infections. They can be fungal, viral, opportunistic infections, and so definitely want to make sure that you're making the patient aware of this fact, and that they don't have certain comorbidities that may make them even higher risk. Before starting, you would obviously want to get CVC and CMP, and then you would want to screen the patient for TB and hepatitis B as well, probably hepatitis C if you really want to be thorough, and make sure that they don't have an underlying infection there. And then there's also some thought that they could potentially exacerbate heart failure. And so you want to at least use caution in someone who has concomitant heart failure. If possible, we could avoid use and try a different method. But if nothing else, you just want to use caution and watch for worsening of that patient's CHF.
Right. It does appear that there is an approved sub-Q infliximab now.
Yeah, the studies I was seeing that were reported from that conference were calling it one of those. You know how they like to code their drug, like PB 1 whatever 568, and then later on it's just like Humira.
Zim,
they kept referring it.
Yeah,
I just say they kept coding it as that like molecule or something. So
right, Zimfintra looks like the first one. It was the first one that was approved. As far as what the guidelines recommend for these, so we mentioned those three: Remicade, Humira, and Cimzia. The guidelines recommend for moderate to severe Crohn's disease the use of TNF alpha inhibitors over no treatment for induction and remission. They do note that this recommendation is of moderate certainty with Remicade and Humira and low certainty with Cimzia. So if you're going based on that, you probably use Humira or Remicade first. And for practical and cost reasons, you'd probably end up using Humira first, which seems to be what ends up happening the majority of the time that I see. For in terms of induction, in patients with moderate to severe Crohn's who are naive to a biologic drug, the guidelines do suggest using Remicade or Humira over Cimzia for that reason. In patients who previously responded to Remicade, they recommend the use of Humira for induction of remission. And then if Humira was first line, there's some lower quality indirect evidence to suggest using Remicade as a second line agent in that case.
Yeah, and I think that's the important thing is even though the Cimzia is approved for Crohn's, the quality of evidence is definitely lower certainty. And so the guidelines made a big point of, they brought that up several times throughout the 2021 guidelines. So it's out there and there may be...
If I'm not mistaken, don't take it to the bank, but I'm pretty sure Cimzia has some better safety data in pregnancy. And so I see it substituted for patients who may become pregnant. I'll see that sometimes.
Okay, gotcha. That's good to know. But I guess efficacy-wise, the data just may not be as thorough or as impressive as the other two.
Right. I feel like the only time I see it is if the others, they've cycled through those or in the situation of pregnancy.
And for those of you who may be wondering, like, what about combining some of these, induction therapies like infliximab and maybe a thiopurine? You're in luck because there was a study done called the Sonic trial. Someone was a big Sega fan at the drug company, but they took infliximab and then compared it to azathioprine and then compared that to infliximab plus azathioprine. And the patients that were included in the study were those that had an activity index score of 220 up to 450. So they didn't reach that most severe fulminant, but definitely in the moderate to severe category. And patients could not have had a history of previous treatment with immunosuppressive drugs or biologics. So these were brand new to therapy patient, or treatment naive patients. And the primary outcome that they were looking for was the occurrence of corticosteroid-free clinical remission at week 26. And what they found is that the combo was superior to infliximab alone with a number needed to treat of only 8, which is pretty low as far as number needed to treat goes. And the combo was also superior to azathioprine, which I'm sure we all could guess. And that number needed to treat was only 4. So the combo definitely seems to be pretty effective, especially if you're comparing it to monotherapy.
Right. And the guidelines kind of reflect that. So they say for induction, they recommend the use of, if monotherapy is what is going to be done, they recommend a biologic as monotherapy over a thiopurine. But for induction or remission for patients who are naive to biologics or immunomodulators, they suggest the combination, Remicade in combination with thiopurines for induction and maintenance, for example, over Remicade monotherapy. There's some other evidence to suggest the combination of Remicade plus methotrexate may be more effective than Remicade by itself as well. And then they give a similar recommendation for Humira. Humira combo with the thiopurine is better than Humira by itself for induction and remission, and potentially Humira plus methotrexate.
And I'm sure y'all are tired of me talking about the semantics of this, but this is a good example of where they actually use the phrasing to recommend the use. And when they're talking about the biologic monotherapy over the thiopurine, they recommend that versus the other suggestions or suggesting the use of like the combo over monotherapy. And that just, again, based on the level of evidence that they have, the quality of evidence. And so obviously much higher quality of evidence when they actually say full on recommend the use. So
right.
I'll get off that topic, but just to make sure we're all clear on that. But yeah, and I do think it's also a good thing to note that evidence for the methotrexate in combo with infliximab and like also the adalimumab with methotrexate is definitely like indirect evidence that they're using, but it's maybe worth the shot if the patient can tolerate it. So they do kind of point that out pretty specifically.
Right. At least the safety's there. It's not like they're contraindicated together or anything.
They're like, well, we need data, so just go ahead and combine them and let us know how it goes.
Let's just see what happens.
All right, so non-TNF alpha biologics. We have a few different options here. The first one being the anti-interleukin 12/23 antibody, ustekinumab or Stelara. This is available as IV or sub-Q, and it works by blocking the biologic activity of both of those interleukins, 12 and 23. It inhibits the receptors for these cytokines on T cells, natural killer cells, and antigen-presenting cells. And it does also increase the risk of serious infections. And again, not just bacterial, but it can be TB, invasive fungal, other opportunistic infections. And a negative TB test is required at baseline. And then you would want to do periodic monitoring depending on how long the patient is going to be on the medication. Treatment of latent TB, if the patient is found to have latent TB before starting it, it needs to be done before initiating treatment. So even if it's not active, you still want to treat the latent TB appropriately before, starting Stelara in the patient.
Yes. Make sure to get those TB tests ordered because that will delay therapy if you forget. Most of the time, if they're seeing a GI specialist, it's going to be part of the normal lab
workup.
Draw, because you can get a lab draw now, and so it'll just be a part of that whole thing.
Yeah.
There's also integrin
there's
receptor.
Zero chance you're not going to be doing sorry, man. I didn't mean to interrupt you. I was going to say there's zero chance of not doing a prior authorization, and so
that's
correct. They're gonna want to see all that stuff for a prior auth. So just go ahead and get it at baseline, and that way you can get the medication hopefully approved in a timely fashion.
Exactly. There's also integrin receptor antagonists. So vedolizumab, Entyvio. It's another IV option that is for Crohn's and UC. They recommend that if the patient has not seen benefit by the 14th week of therapy, to discontinue it. It has warnings related to infusion reactions, increased risk for infection, possible liver injury that would need to be monitored for. They recommend having all vaccines up to date before starting therapy. And then there's some more kind of benign adverse effects like headache, arthralgia, nasopharyngitis. So for the monitoring, monitor LFTs, also monitor for neurologic symptoms, and then also a TB screen for this one as well.
Yeah, and the vaccine thing is important, not just because it's like we're talking live vaccines, the non-live vaccines, also just because obviously the immune response may not be as immunogenic as it could be if the patient wasn't on one of these meds. So
right,
it's definitely important to get them caught up.
Yep.
Now we do have another integrin receptor antagonist that has fallen out of favor, if you will, compared to previous recommendations under the name natalizumab or Tysabri. And this is a medication that I want to say it was originally approved for MS. I think was the original indication for it, but it is approved for Crohn's disease specifically as well. Not ulcerative colitis, but Crohn's. And it was, part of the suggested or potential uses in the guidelines previously. And it does work mechanistically by binding subunits of the integrin molecules. So you block the ability of integrin to interact with adhesion molecules, which is then going to prevent the inflammatory cells from migrating to the GI tissue. It's also an IV formulation. The issue is the box warning that's associated with it. It does carry a risk for progressive multifocal leukoencephalopathy, PML, which is a viral infection of the brain, which oftentimes leads to death or at the least severe disability. And so this is a medication that's only available through a REMS program called TOUCH. And the patient basically needs to be checked for that John Cunningham virus antibody and show that they have a negative response to that before they could be a candidate for this medication. The other adverse effects that have been commonly seen infusion reactions, headache, fatigue, depression, abdominal and back pain. And this one is something that cannot be used with other immunosuppressants. So that's, another big difference from other potential options.
Right. Yeah, keep an eye out for that PML acronym when you're listening to like drug commercials. If it's a drug for MS, you'll probably hear that reference because a lot of them carry that risk. So as far as the guidelines go, for induction and remission, they recommend the use of Stelara over no treatment in moderate to severe Crohn's. They suggest the use of Entyvio over no treatment in moderate to severe Crohn's. And they suggest against the use of Tisabri. So pretty much tracking with everything we said. They make the caveat, kind of like Mike said, if a patient is John Cunningham virus antibody negative, who puts a high value on the potential benefits of this medication or of getting symptom relief, and lower value on the risk for PML, who will adhere to the REMS program and monitoring for the virus positivity, then you could consider Tisabri. So they put that caveat in there.
Yeah. I like it. They said they put a higher, value on benefits, but really they're not that worried about PML at all. Even though it
if
could
they're
be
really worried
horrific
about their symptoms and not so worried about the risk of death and disability from this infection,
and they like to stare death in the face and keep on rolling, and go ahead and give them natalizumab.
It's probably one of those situations where they cycle through the things and they just
exactly
the risk outweighs benefit outweighs the risk at that point.
Yeah, for sure. And so, again, some other recommendations in adult outpatients, moderate to severe, who have never responded to anti-TNF alpha. So basically, they're a primary non-responder. You've tried one of those agents, didn't get any benefit from it, then the AGA recommends the use of ustekinumab and then suggests the use of vedolizumab and Entyvio, basically over no treatment at that point for the induction of remission. And then the induction, or for the induction of patients, who have previously responded to infliximab or adalimumab, so they're basically a secondary non-responder. Then the AGA recommends the use of ustekinumab and suggests the use of Entyvio as well. And so same kind of thing, but whether the patient's been on a TNF alpha inhibitor or not, it doesn't really change it. It seems the Stelara has more impressive data. And then for patients with moderate to severe Crohn's, the AGA makes no recommendation regarding the use of ustekinumab or vedolizumab in combination with thiopurines or methotrexate or over the biologic, non-TNF alpha inhibitor as monotherapy when it comes to induction or remission. And I will say that, even though they don't make a recommendation, it's the immunogenicity tends to be increased when you talk about TNF alpha inhibitor in combo with those. I've heard some GI folks say it doesn't necessarily make sense to use like the Stelara or Entyvio with thiopurine because you don't really get that same synergistic benefit. But that being said, it's one of those things that you may still see some patients being put on it just for the hope of maybe seeing a little small increase in benefit, but they don't really make a recommendation about that, just probably because there's not, really that the data available. And then in the outpatient setting, if they're on combination therapy, the AG also does not make a recommendation for the withdrawal of either the immunomodulator or the biologic over ongoing combination therapy. So that's the hard thing is, how long do we keep these patients on these biologics, especially if they're on a combination of immunomodulator and a biologic? There's not a lot of long-term data with these, especially not when you compare it to something like methotrexate. And so, a lot of that just kind of is very patient-specific and sort of, best clinical judgment that you can while weighing the safety and potential risks and all that long term that we may not be aware of. And so they don't make a recommendation on that, but hopefully as time goes on and we have more data that's collected, we'll actually have some kind of a recommendation on long-term, treatment.
Right. All right. So to summarize, as we promised, we'll kind of summarize induction and then maintenance therapy as well. So in terms of induction, the ideal therapy, as far as efficacy goes, would be Remicade plus azathioprine. There's less ideal options, but certainly are done, like Remicade plus or minus mercaptopurine, Humira plus or minus the ethioprine. You may see that if the convenience of a infusion is an issue. Also, Remicade plus or minus methotrexate, Humira plus or minus methotrexate, and then Cimzia, with or without ethioprine or methotrexate, only if no other biologic is available for whatever reason, cost or whatever it may be, or if they've gone through them. Second tier induction therapy would be methotrexate, the injectables, not the oral. And then lastly, you're thinking oral corticosteroid, which can certainly be done, but because of the concerns, we want to try to use these other therapies that don't have as many side effects and concerns.
Yeah, for sure. Now, if a patient is started on their induction therapy with a TNF-alpha antagonist and that induction therapy fails, then you could consider adalimumab plus or minus the thiopurine or methotrexate if the initial med was infliximab and the patient had like a partial response, and vice versa if it's the other way around. If the other option would be to at that point consider ustekinumab. Now, if induction therapy fails with a TNF-alpha antagonist and ustekinumab, at that point, Entyvio would definitely be the next best thing to go with. And as far as the maintenance of remission, the first line maintenance of remission, we would want to either continue the biologic. Now, like we said, the combo therapy, if the patient was put on combo for the induction therapy, that's going to be a kind of a discussion between the clinician and the patient to see if the combo is going to be continued, or if just the biologic is going to be continued by itself. If the biologic is continued, you stop the thiopurine, methotrexate, then at least have that as a potential option. If they do have a flare up, you could potentially restart the combo later on. Kind of going back to that induction therapy. There's also the case where the patient doesn't feel comfortable being on a biologic long term, even as monotherapy, and so there is the potential to use a thiopurine or methotrexate as monotherapy. We mentioned not using thiopurines as like induction therapy when it comes to monotherapy, but for remission, you could potentially keep them on something like azathioprine as the maintenance of remission. And then if steroids were used to induce remission, then you would want to either consider no maintenance therapy at all, or at that point, maybe starting a thiopurine or methotrexate as monotherapy. You would not want to continue steroids on, indefinitely for the maintenance of remission. Right.
And I mentioned Humira being a more convenient option if you don't want an infusion. But of course, as we noted earlier, with Remicade having a subcutaneous option, if that is something that is available to them, via insurance or payment method, then that's an option. And Stelara has the IV and sub-Q versions that can be transitioned to after induction too. So,
yeah. And all of these do have like patient assistance programs and things for patients who are not insured. Not all of these, and definitely some things change year to year, but recommending patients to see like a federally qualified health center or at least a clinic or facility that has access to 340B pricing for their pharmacies, that can definitely help patients get access to some of these. The prices can be very high on a lot of these biologics. And so access is an important thing to familiarize yourself with, I feel like, especially for pharmacists, because, the patients you can have all the recommendations ready to rock, and then the patient can't get it, then no good. So lots of patient assistance programs out there, and there are definitely ways to get patients on these if you spend some time.
The thiopurines are more affordable. Methotrexate oral is affordable, but the injectables are more expensive, which is what you got to use in Crohn's. Rasuvo and Otrexup, I think, are the two, and so you'd have to consider cost for those.
Yeah, absolutely.
Though I think it comes in a vial.
All right, so that's the 2021. Yeah. but yeah, that's the 2021 guidelines, and I hope that was a somewhat helpful overview of it. Cole, is there anything else we need to go over? Because I think we're about out of time.
That's all I got, man.
Cool. Well, thank you guys for listening, and also too, if you want to have a more lecture style, I know you've heard us mention this several times, but lecture style content, check out our Patreon, which is patreon.com/coreconsultrx, and you'll get access to all of the lectures that I put up there. That basically a lot of it's content that I do for my PA students, and tons and tons of different disease states in the management from a pharmacotherapy standpoint, reviews for those, and they also include the slide sets and all that you can download. So it's like $3 a month, or it's like $30 and some change for the whole year, and you get access to everything. And then also if you do the annual membership, the $30 and some change option, you'll get access to the Landmark Clinical Trials Review book by Dr. Alex Poppin, and he has now released his third edition of his book, and he has given me permission to include the third edition for the annual members that sign up, and so very, very nice of him. But that's it. I think it's 175 studies now that he goes through, and gives very detailed summaries, and it can be a very good reference tool. But you'll get a digital copy of that totally for free, thanks to him and for sponsoring the podcast. But check that out, and if you have suggestions, you want to be a guest on the show, anything like that, just want to say what's up, definitely reach out to us on social media, or our emails will be in the show notes below. And check out Cole's search engine plugin too. It's very, very convenient for those of you who have to do a lot of literature searching. And thanks to Free C as always. And thank you to you guys for continuing to listen to us. Sorry the episodes haven't been as frequent month to month, but as we get more used to this whole 2-kid thing, we'll hopefully be more frequent as we go. But bear with us, and thanks for listening. We'll see you guys in the next one. Have a good night.